everyone, and thank you for joining today's webinar, Pelvic Pain, Cramps, and Hormones, Why Does Our Body Communicate This Way? I'm Georgia Weston, and I'm the Executive Director of CHYP, Creative Healing for Youth in Pain. We're a nonprofit providing educational resources, exposure to creative healing experiences, and social support online. We have a great discussion planned with your live Q&A questions. We would like to ask everybody to please keep yourselves muted and cameras off so we can all enjoy without distractions. But of course, you are able and encouraged to type your questions into the Zoom chat throughout the discussion for our speakers to address. And now I am pleased to introduce CHYP's board member, Dana Pacholski, who will be moderating our conversation with our guest, Dr. Andrea Rapkin. Dana also serves on the board of the UCLA Resnick Neuropsychiatric Hospital, is co-chair of the Regenerative Medicine Institute campaign for Cedars-Sinai, the vice chair of Cedars-Sinai's Innovation Center project for the Board of Governors, and is a board member for the Caton Children's Museum. Dr. Andrea Rapkin is a professor in the Department of Obstetrics and Gynecology and director of the Pelvic and Vulvar Pain Clinical and Research Program at the University of California, Los Angeles. She is an internationally recognized leader in the study of chronic pelvic and vulvar pain and premenstrual mood disorders and has authored over 120 articles, chapters, books, and reviews in this area. Dr. Rapkin initiated one of the first multidisciplinary pelvic and vulvar pain clinics in the country. Her goals were to offer comprehensive and innovative clinical care and access to current research studies for women suffering from complex chronic pelvic and vulvar pain disorders. So now I will hand it over to Dana and Dr. Rapkin to get our discussion started.
Thank you, Georgia, and thank you, Dr. Rapkin, and thank you all who are joining us today. We're really excited to have a great discussion about pain and pain starting in the lower abdominal region and what that means. So, Dr. Rapkin, thank you so much. I think
you're welcome.
I think the best way for us to really start our chat today is to really talk about our cycle so that we have some basis of comparison and understanding of why things are happening when, and then we can get into how the pain signaling is starting and what we might be able to do about it. So if you'd walk us through our cycle to start, we would appreciate that.
Okay, sure. So the menstrual cycle varies in length. In other words, the duration from the first period to the next menstrual period varies in duration from about 21 to 35 days normally. And during this time, in the beginning of the cycle, which is called the follicular phase, the little eggs are developing and getting ready for ovulation and then for fertilization. That is really the purpose of the menstrual cycle. And so in the early part of the cycle, this is dominated by a rise in estrogen called estradiol, and then a big surge in estrogen at the middle of the cycle. Which if you have a 28-day cycle would be about day 14, but if you have a 35-day cycle, it would be 35 minus 14, and I'm not going to do the math in my head right now, but I think you get the picture. So with ovulation, you then have the egg coming out of the ovary and being able to be fertilized. Fertilization, if it is going to occur, occurs in the fallopian tube, which is little tubular organ coming off the uterus that can pick up the egg from the ovary, and fertilization occurs. And the second half of the cycle is dominated by progesterone. Now, progesterone causes the endometrial or the uterine lining to thicken, and what it's doing is creating a cushiony sort of nest for implantation of this embryo if it does occur. Now, if there's no embryo, then obviously the endometrial lining has to shed, and that shedding is what becomes the menstrual period. So at the progesterone rises and then it comes down, and when it comes down, there is a shedding of this uterine lining, and that is the menstrual period.
And what would one feel? Would they feel anything typically or even atypically when you're in that first 14-day phase? I mean, would you have more likelihood for a cyst or for anything that you would be having some pain signals telling you, hey, something's happening down here?
Well, the first 14 days, let's eliminate the first 3 to 5 to 7 days of menstrual flow, because during that time, of course, we'll get to that, what kinds of pain and signaling can be happening at that time. But once you end the menstrual flow and until ovulation, that's usually a time of significant well-being. It's a time of increasing estrogen. Yes, there's some follicular development, little egg sac development, but generally not large enough to be perceived as painful. So it may get to be about, oh, the largest this big, about 3.5 centimeters at the most. And generally that's a time of really, let's say, good moods in a way. We don't see premenstrual symptoms during that time, and generally less pain during that time.
And then when you head into the next phase, when we get into the progesterone phase, what would you typically say are the common feelings that the body is sending us signals about?
Yeah, well, first of all, with ovulation, some women do feel a little bit of pain because of the fact that when the egg extrudes from the surface of the ovary, there's a small bit of blood that may come out at that time in the abdominal cavity. In German, it's called kleine Regle, or a small shower. So sometimes that accounts for an ovulation pain, which can be significant with some people, but often not noticed. Then during the progestin dominant phase is the time when a number of women may start to have PMS-like symptoms, or very severe PMS called PMDD, which may occur somewhere between 5 and 7% of women, associated with the rise and then the fall of progesterone. And as progesterone comes down and the uterine lining starts to break up to some degree, a number of chemicals called prostaglandins are formed. And these prostaglandins will increase pain for the uterus, and even in more widespread areas, because they are a signaling molecule and they start to be produced prior to and during the menstrual flow.
And what type, when you say PMDD, what would that entail? Is that moodiness? Is that, and then we've got this pain signaling, and is there anything else that goes along with that that we can talk about?
Yeah, sure. I mean, if you look at premenstrual symptoms, in some ways they can be very normal. We call them maliminal symptoms. They just tell us that someone is ovulated. So most women will have some breast tenderness, bloating, maybe a little bit of irritability and more emotionality in the 5 to 7 days, or even up to 2 weeks before the period. As these get to be more severe, and I would say not more than 20% of women will have what we might call premenstrual syndrome, where the symptoms are bothersome, but they're not incapacitating. They may consist of anxiety, irritability, tension, mood swings, achiness, abdominal cramping, bloating, this sort of thing. Premenstrual dysphoric disorder, on the other hand, consists of symptoms that are really debilitating or really interfere either with work, home, school, etc. And these symptoms can occur for up to 14 days before the period, and then they should be gone by somewhere about day 4 of bleeding. And as I said, that is a much smaller number of women.
And for those small percentage of people that have that, I mean, that's a pretty healthy window to not be feeling like yourself. And especially for our population, where our communication in our system with the group that is with Creative Healing for Youth in Pain, we know the signaling is a little louder than it might be for everybody else. So what would you talk about that they might do during those phases? Now that we've explained those phases, what do we recommend for those people to do to help mind-body connections, both over the counter and anything else you'd recommend?
First of all, I think it's important to recognize when these symptoms are occurring and the fact that they are cyclic. And that also helps to give a sense of control, because not only is it predictable, but you start to understand, why this is happening, that it's happening in relation to a hormone fluctuation. It doesn't mean the hormones are abnormal. It's the way the brain is responding to change. We know no one likes change. The brain does not like change. And this is the way the brain is responding. So there are different grading scales that can be downloaded from the internet for free. One is called the Daily Rating of Severity of Problems, the short form DRSP. And that allows you to mark your symptoms every day along with the bleeding for 2 months. And that will, number one, be able to give a physician a diagnosis for you if you do end up needing to go to that point. And number two, can help you understand really what's going on with your cycle. So 2 months of that can be very useful. And it's probably more helpful than just an app where you're tracking your periods, because you can also circle the severity of the different mood and physical symptoms on this daily rating of severity of problems. So for mild, moderate symptoms, what tends to be very helpful is stress reduction, exercise, increasing calcium and vitamin D. We know that many women in general don't get enough calcium in their diet. And it has been shown in adolescents that the amount of calcium intake with dairy or other calcium-rich foods can be correlated with mood and with onset of PMS symptoms. So we want to make sure there's enough calcium, vitamin D, as I mentioned, and aerobic exercise does help physical and emotional symptoms. And although there are not a tremendous number of studies, there are some studies looking at mind-body approaches, for example, mindfulness-based meditation, various forms of stress reduction. These can be very helpful.
That's great. And I have two questions going back to the supplementation. So in our population, they're already taking a lot of supplements and things. So if they weren't able to take more D and more calcium on a regular basis, is there a time in the cycle that you'd recommend to take those supplements? Is there a better time or more optimum time, I should say?
I mean, I really think it should be taken throughout the month. This can be either done by sitting down with your health provider or nutritionist and figuring out which foods should be included in the diet so that you do have enough calcium, or could be added to the supplement to be taken. It also helps with building strong bones. As you know, once you get to my age, you worry about your bones. So you want to have a good, strong bone mass before you get into menopause. So I think throughout the month is really ideal.
And is there a recommended dosage that's been studied that helps with this, or just
it's basically the same as the recommended daily allowance. It's about 1,000 to 1,200 milligrams per day. Keep in mind that, say, an average cup of yogurt would be about 300 milligrams of calcium. And so if you had 4 dairy portions, which would be adequate. There are also calcium-rich foods like green leafy vegetables and eating fish with the bones. I don't know how many people would do that. But in supplement form, they usually come in 500 or 600 milligrams, and you would take it twice a day because you can't absorb all of that calcium at once.
I really like adding food into the equation as our supplements in addition, and I love being able to give the population something to work with. Again, what you said, which is it's a comprehensive process in order to help our body change the signaling. So I love food as part of it, not just supplements, but obviously knowing supplements help is great. So let's talk about pain and the different types of pain that the body is sending us messaging on. Is there a way to maybe describe any difference in, and again, we're talking in such general terms, but is there a way to say, okay, at this part of the cycle, the body might feel like this, like you were talking about with the dropping of the egg, the second, cramping. And because I think a lot of people during their cycle, 28, 30, whatever their cycle is, don't know if it's abdominal or pelvic. Is it gastro, or is it part of their hormonal cycle. So I'd love to if you could walk us through that for a bit.
Sure. It's really quite complicated to sort out for a number of reasons, but just taking a step back, in terms of the types of pain that might start to occur in the progesterone, which we call the luteal phase. And keep in mind, this is women who are not taking an oral hormonal contraceptive, because we can go into that down the line. But during the progesterone dominant phase, as the progesterone starts to rise, we would see more bloating and breast tenderness, which in some people, particularly if you have your pain amplifiers sort of tuned up, it may be perceived as significant breast pain. The bloating could be considered to be significantly uncomfortable. We really don't know what causes the bloating, actually. It's thought to be possibly fluid retention in the abdominal wall and in the wall of the gut. And some women actually experience a weight gain during that time. Now, closer to when the progesterone starts to fall, and I mentioned the prostaglandin release, that's when you might start to feel more abdominal cramping, discomfort, even generalized myalgias, meaning muscle pains and joint pain, just because of these prostaglandins. And there's a sort of a slew of other little pain-producing chemicals that are starting to be produced from the uterine lining. And not only that, but the progesterone does slow the transit in the gut. So there's more constipation in the premenstrual time. And then as the prostaglandins are released and at their peak with menses, there can be diarrhea. So it starts to look like this is a gut problem, but it's really just how these hormones affect the gut. At the same time, though, the nerve supply to the uterus and ovaries overlaps with the nerve supply to the bowel and even the bladder. So if one organ is acting out, like the uterus, producing a lot of pain-producing chemicals and contracting because of the prostaglandins make the uterus, contract, this overflow of signaling can also affect the organs that have the same shared innervation or nerve supply. So at that time, there may be more pain in the gut that if you already have some low level or some high level gut pain from irritable bowel or functional abdominal pain, this is going to be amplified more. This is going to be tuned up because the uterus can affect the same way it can affect the bladder. And some women have bladder pain, and the bladder pain is going to be worse premenstrually and menstrually. And even arthritic pain and migraine and various pains will be worse during this period of time.
And the migraines, do you see that a lot of people that come to see you have migraines throughout their cycle? I mean, I've heard, we hear it in our daily chatter with friends, oh, I've got a migraine that's hormonal. But what does that really mean in terms of our cycle, and how does it affect a headache?
Well, let's think of a congestive kind of headache, like we think of the congestion, the increased blood flow, everything that's happening in the abdomen. That sort of a headache is not a migraine, but maybe more prominent sort of premenstrually and menstrually. Now, with someone who has migraines, they can be hormonally mediated, and they're mediated a little bit differently than PMS. So really, it's the surge in estrogen at the middle of the cycle. As that estrogen starts to come down, that can trigger migraine headaches. So it's the withdrawal of estrogen as opposed to PMS, which is more related to the onset of progesterone. But so in general, individuals with migraines will have headaches throughout the cycle, but there may be more premenstrually and menstrually. And sometimes medications that prevent that rise and fall of the ovulation, hormonal contraceptives, are actually useful to prevent these migraines from occurring at the time of the premenstrual and menstrual phase. Now, certain people would not be recommended to take estrogen-containing hormonal contraceptives if they have complex migraines with substantial aura, but short of that, they may be very helpful.
And is there, again, could they use that system that you referred to earlier? And if you would rephrase that, the name of that system, where you could circle your cycle and your body's communication during the cycle, would you see those headaches coming on again at that transitional time, or do you see those headaches coming on throughout the cycle? And would they be able to find that and then say, oh, you would recommend oral contraceptives to help with that or not help with that?
Yeah, well, in general, someone who's a migrainer, they may start to occur around puberty. They generally are not just in the premenstrual and menstrual phase. However, yes, if they add on to their daily rating of severity of problems when headache is one of the items on that list, so they're circling that it's severe during that time. What we would try to do is give a medication that would blunt that rise and fall of estrogen, and see if that would be helpful. In general, usually there'd be a medication for aborting migraines that would have been already prescribed by the primary care or neurology. And if that is being used too frequently premenstrually or is not working, then another layer can be added.
And I appreciate you talking about that. And I love we really appreciate the interdisciplinary care that we get from multiple doctors, because it does take a team. And I love the chart. And since we've been talking about oral contraceptives, maybe we should give that a few minutes right now to talk about, I hear a lot with the young girls that their pain, that they're getting such bad period pain. And again, everybody's talking in such general layperson's terms. That's what they say. And then all these teenagers are being put on oral contraceptives. And if you could kind of walk us through why is that the recommended thing at the moment, and what do you see that as helping, or maybe what you'd recommend differently or in addition?
Okay. Yeah, okay. Well, I think that's an excellent question. First of all, when these prostaglandins are produced, they sensitize nerve endings. They also cause contraction of the uterus. Sometimes the contraction of the uterus can be so strong that it decreases the amount of blood supply coming into the uterus. So there's almost like less blood supply there. And it of course can be very painful and debilitating. Now, since the prostaglandins are one of the prime chemicals, anti-prostaglandin medicine are usually the first choice for menstrual pain. And once these medications went over the counter, what we found is that young women were not taking them properly because you're not taking an actual prescription strength and maybe not starting it at the right time of the cycle. So before we get to oral contraceptives, we might want to talk a little bit about these non-steroidal anti-inflammatory medications like ibuprofen or naproxen. You may know them as Advil or Anaprox. These are some of the trade names. And these medications block the formation of prostaglandins. So when you're taking something that's going to block the formation of another chemical, if you take it late, in other words, you're already in very significant pain, that means that the horse is out of the barn, so to speak. The prostaglandins were already formed, and the medication you're taking is not going to work until these prostaglandins are metabolized and the next batch is being made. So you really need to take these medications early, i.e., if you have a very regular cycle, even start the day before you expect the flow, or if the cycle is more irregular, sometimes 27 days, sometimes 34 days, you don't really know, then you would take it at the first hint of any cramping pain or blood. You take the medication. Now, how much do you take? So the over-the-counter dose may be adequate, which, for example, for ibuprofen might be 400 milligrams. That's 2 of the Advil tablets. But if you are having still a lot of pain, the prescription strength for ibuprofen is actually 600 to 800 milligrams taken every 6 to 8 hours. And as I said, we call it preemptive. I mean, get it before it really gets bad, and take it for the first few days of your menstrual period and maybe the day before. And this is not harmful to take in this fashion as long as you don't have an allergy or certain other contraindications that are very uncommon. Now, when that doesn't work, and maybe you've tried 2 different, well, I'll call them NSAIDs, non-steroidals, because they work a little differently. So maybe you've tried the Anaprox and the naproxen sodium, you've tried the ibuprofen, that's when we start to think, okay, what's another way to lower prostaglandins in the endometrium? And another way is with a hormonal contraceptive, because the birth control pill thins the uterine lining and it alters the chemistry of what's going on when you then have the withdrawal bleeding. So if you take a birth control pill that has both estrogen and progestin, you really, when you have a bleed at the end of that, when you have your 21 active pills and then 7 placebo pills, which allow you to have a period, it's not anything like a normal menstrual cycle. There's no egg development, there's no rise in estrogen, there's no ovulation, there's no production of progesterone by the ovary. So what you have is a combination of estrogen and progestin, not progesterone, but a chemical like that gives you a continuous level of hormone throughout 21 days. And then when you stop it, there's a shedding of the lining. And the lining, when the lining is shed when you're on a birth control pill, it's much less painful because there's less prostaglandin. Having said that, if the period is still quite painful, it is perfectly fine to eliminate the bleeding altogether. So it's not the same as if you don't get a period because your hormones are off. Basically, you're just continuing the low level of estrogen and progesterone and not taking those 7 days off and just continuing it and suppressing the menstrual bleed. Now, one would say, well, why doesn't everyone do that? I mean, who really wants to have a period? What is the downside of that? The main downside is that ultimately the uterus may want to bleed. So you can start to have this breakthrough bleeding, which is not harmful, not dangerous. Doesn't mean the birth control pill isn't working if you're using it for contraception, but it's very annoying to be bleeding outside of a cycle. And if that starts to happen on a continuous regimen, we always recommend, well, take 4 to 7 days off. Don't do this more than once a month. Let the lining shed evenly and then reset again. And maybe you can get a 3 to 6 month period of time with no bleeding and no pain. And that can be very helpful.
I mean, I really appreciate that description because I've never really heard it before in that way. So understanding what our body's doing is really great. I think, again, with mind-body connection and everybody talking about mindfulness, knowing, okay, these are the days this is happening, and here's the things we can do. So in addition to taking oral contraceptives and or taking NSAIDs, are there movements, stretches, yogas, or anything that we can do where we get our body to either help produce something else naturally or to alleviate the signaling that's happening throughout the cycle?
Yeah, I mean, definitely. There's no doubt that exercise helps. And sometimes it's difficult to really exercise during this time. And if that is difficult, yoga is a kind of exercise that often can be done during this time. And certainly yoga is very helpful for pain and cramping during this time. And also the breathing. The breath work that goes along with yoga, which overlaps with the kind of breath work that's done with mindfulness-based meditation, is really key in helping us to relax muscles. One thing that can happen when you have a lot of pain in the pelvis is that you start to tense up your muscles because your brain and your body is sort of trying to protect itself from this pain. And if it were an acute problem, say you had an injury, it's helpful to have everything be tense and painful and you go to bed and rest. But when it's a chronic problem, it's not helpful for our body to do that, but it does it anyway. So we start to get these tender, tight muscles in the abdomen wall. They're all those muscles that you might think of if you're trying to do a sit-up and make them stronger. There are 3 or 4 sets of muscles there, and they can get tight, spastic areas with trigger points, which are very tender points when you touch them, and they can be another source of pain. The other muscles that we don't think about very much are the vaginal muscles. So the vagina is basically a muscular tube. I mean, that's what it is. It's lined with muscles, and they have complicated things they have to do. They have to hold urine or release urine. They have to hold stool or release stool. They may be involved with sexual functioning down the line. But this is another area where the muscles can become tight and tender when you have pain. Also, by the way, there's a neural innervation overlap. So I mentioned the overlap in the nerve supply between the uterus and bowel and bladder. Well, guess what? The same nerves innervate the lower abdominal wall and what we call the pelvic floor, the vaginal muscles. So when we start to have pain in one area, the muscles tighten, the muscles become part of the pain. And what's the best way to relax those muscles? It's to do this mindful breathing and yoga and different types of mind-body work and breath work that make it very difficult to really hold on to a significant muscular contraction. But given that this is unconscious, we first have to become conscious of it. And that's where sometimes it's helpful to check in with your body. Like a lot of people who hold tension in muscles will have TMJ, temporomandibular joint, and you're grinding your teeth. And the first person to notice that you're doing that at night may be your dentist, in fact, and you may have a mouth guard that you wear. But as you become aware of it during the day, you can be aware of when your jaw is clenched. It's hard to be aware at night. As you start to become aware, you can become aware of when you're tightening your pelvic floor muscles. And you may check in and say, oh, I'm tightening everything there. And then you do your nasal breathing, your mindful breathing, and get that to relax. And so that can become a habit throughout the day. I don't think of mindfulness as something that you sit there with your eyes closed 10 minutes twice a day. I think of that breathing in that state to be something that you dip into many times during the day. Maybe not when you're driving, but many times during the day.
Well, it goes hand in hand with what Dr. Zeltzer always talks about and what we try to help kids that come to creative healing and pain, because what you're talking about is acknowledging that you have pain, but also acknowledging why you're having pain and then doing something different so you can release the pain, right? Just being aware of it, you can either latch in and get that repetitive, I have pain, I get pain now, or you could say, I have pain, but I know it's due to this, this, and this, because now I'm aware of what my body's doing. So I'm going to go over here and I'm going to try to move away from the pain, right? I'm going to do anything else. So when we joke with creative healing with youth of pain, if you get out of bed every day to the right and you're doing the repetitive motions every day, right? Because when we have pain and we have anxiety, we start to narrow our playing field and we start to reduce everything from fear. Maybe go left. Try dancing. And everybody will say, well, I'm in pain, I can't dance. Okay, well then try a yoga pose. Try anything different than what you were doing to change the body's neural signaling. Is that the best way to describe it? Is there another way to
No, exactly. When I have individuals who have significant pain, what we're really trying to do is work with whether it's psychologists or meditation teachers, yoga teachers, and to be able to, as you said, expand the repertoire to improve resilience so that we have a very stressful environment we live in, and we can't always change the stress around us, although there are things we can do to try. But what we're really trying to do is to alter how our bodies react to these stressful times, to acknowledge them, and then to alter how we react to it. And as you mentioned, build up different sorts of repertoire of whether it's physical activities, things that you like to do, that you enjoy doing, that you should really give yourself time and credit for doing during this period of time, and not to be too hard on yourself, really, not to be judgmental, just start to do things that are really good for you.
And I can see how a teenager, particularly a teenage girl, is having these cycles, is living in a state of anxiety. I'm going to get my period. I'm going to have pain. I can hear the inner dialogue coming. And then the mom's saying, well, do something different. Let's do something. And maybe we can talk about, because one of the questions that's come up, and it's something I know from a ton of my friends, is if you have a teenage girl and as a mom, you're a little reluctant to just put them on oral contraceptives, maybe because we're not aware of the cycle you just described, or maybe we don't want to put them another thing in their body yet while they're in these really important stages of growth. But how would you talk to a mom who's been reluctant to put their 17-year-old with very painful periods on oral contraceptives, or potentially walk them through what the things they can do for their child, knowing they've had years of painful periods and they haven't yet started an oral contraceptive?
I mean, if the menstrual periods are still painful in spite of adequate NSAID intake and you can do acupuncture, you can do mind body work, if it's still very painful and debilitating, it really isn't helpful to continue to have episodes of monthly severe pain. This can actually tune up those amplifiers that we've been talking about and sensitize both in the pelvis and then even all the way up through the spinal cord into the brain, sensitize our nervous systems to become more pain receptive and pain prone. So it's actually better to take a birth control pill or hormonal contraceptive. These are not harmful. Yes, we don't give them at the time of 11, 12 years old if the growth isn't completed. But once growth is completed and once the time of ovulation starts and menses start to become painful, which is usually more about somewhere between age 14, 15, 16, there's really no downside if you don't have a medical contraindication, and the doctor would know this, to taking a hormonal contraceptive. They can decrease anemia. They can actually decrease incidence of ovarian cancer because the egg isn't releasing from the ovary each month and rupturing the capsule and healing of the ovary. And there are other health benefits. They can decrease premenstrual symptoms and can certainly can be very effective for menstrual pain. It does sometimes require this extended cycle I mentioned, though. And as I said, that is not harmful in any way, not to have a period when it's related to a hormonal contraceptive. Now, some women may have what we call a contraindication to estrogen. In other words, they may have a condition that says you can't take estrogen. Maybe they have had a blood clot in the legs or lungs, or they have another condition where estrogen is not recommended. In that case, there are progestin-only contraceptives that can be used, or low doses of progestins that can be taken that will also block the period, and this would be much more controversial, I think, for a teenager, a progestin-containing intrauterine device. These are basically safe and can be very effective in decreasing this local prostaglandin production and helping to stop the menstrual period without systemic hormone if a young person doesn't tolerate a systemic hormonal regimen.
And you touched a little bit about what my next question was going to be, which is if you have a hormonal, for people that have a history of cancer in their family or hormonal cancer, then would they not be able to take this? But I love that there are some other options. With regards to, I can hear parents in my head, some of them just jump right in. And, is there any study on how long you can be on birth control or any adverse effects of any of this? I know you said it's relatively safe, but have they studied?
Yeah. Well, I mean, first of all, having hormonal cancer in your family is not a contraindication to taking a birth control pill. So someone who has a strong family history of breast cancer, uterine cancer, it's not contraindicated. It's different than what the warnings are for women in menopause to be taking, because in menopause, the body's not supposed to be producing estrogen or progestin. In the reproductive years, the amount of hormone in your body is actually somewhat lower when you're on a birth control pill. It's adequate to prevent osteoporosis and heart disease and all that, but it's actually lower than giving that estradiol, the peak with ovulation and the secondary peak in the second half of the cycle. So the doses of modern hormonal contraceptives are at least half to a third of what they used to be. I mean, when I was a teenager, they were somewhere between 50 and 80 picograms per ml, or the amount of nanograms rather, the amount of hormone. And now we're looking at pills that are between 15 and 20 and up to 30. So the amount of estradiol in the pill is much less. So it really, it's not a problem in terms of health. There is no duration. There's no benefit to something called a pill holiday, being off it for a period of time. We don't have any information that long-term birth control pill usage is harmful in any way.
I really appreciate you clarifying that. And I think I'd like to pivot a little bit and talk about endometriosis, because I think that's used a lot. And I think that kids are reading, unfortunately, teenagers and other people are finding a lot on the internet, not from doctors such as yourself who have dedicated, all this time in the lab and in the clinic. But I'd love if you could describe endometriosis, maybe why that happens. And we might overlap with what you talked about before, but if we could talk about it in terms of endometriosis and if there's anything different for that. And then also, what's the difference between polycystic, what is it?
Ovarian syndrome.
Ovarian syndrome, yes.
Okay, well, that's a whole separate bird, but let's start with endometriosis. So keep in mind, every time there's a menstrual period, when the blood comes out through the cervix into the vagina, a little bit of blood is going to go into the abdomen, actually. And this is normal. This happens with every menstrual cycle. This blood will go backwards through up through the fallopian tubes and into the pelvic cavity. And that blood also carries a little bit of uterine lining called endometrium with it. Now, in an individual who does not have endometriosis, there are cleanup cells in the pelvic cavity that gobble all this stuff up and clean it up. Now, in someone who does have endometriosis or develops endometriosis, these little areas of tissue called endometrium coming from the uterine lining, coming out the fallopian tube, they can actually implant like seeds in the pelvic area, most commonly on the back of the uterus, on the ovaries, and sometimes even on the lower part of the colon. People may read about, oh, it can go in the upper abdomen, it can go in your lungs, your brain. I mean, lungs are exceedingly rare. I think I've seen that 2 or 3 times in almost 40 years. Same with upper abdomen. I mean, the highest it might go, it can affect the appendix, but it doesn't affect the small intestine and the stomach, and all these upper abdominal symptoms are not related to endo. So if these cells are not cleaned up, they are now in the pelvic cavity. They create inflammation because what they do, first of all, they're stimulated by estrogen. So they're made to grow when estrogen stimulates. And these little islands of endometrium themselves produce prostaglandins and a whole soup of other inflammatory mediators that cause pain, sensitize nerve endings there. And also you can start to get some anatomic distortion. In other words, there can be some adhesion, or the area of endometriosis can cause tissues to stick together there. And that may contribute to pain. So we actually don't know the relationship why some people with a lot of endometriosis will have no pain, and some people with a few small areas have a lot of pain. But we have to keep in mind that not everyone who has endometriosis has pain, and not everyone's pain is due to endo if it's found at the time of, say, a laparoscopic surgery. The endo may or may not be the cause of pain that's going on. But in terms of how would you know when maybe you have endometriosis, if the periods are still exceptionally painful with the non-steroidal anti-inflammatory agents and with a hormonal contraceptive, and then you're starting to have pelvic pain throughout the cycle, sometimes accompanied by irregular bleeding. So the period may be heavier, longer. There may be some other bleeding throughout the cycle. If a teen is sexually active, there might be deep pain with intercourse. And in a more severe stage, there might even be pain up high above the rectum with bowel movements. And that can happen if there is enough endometriosis there for the top part of the rectum and the lower part of the colon to stick to the back of the lower uterus. So those symptoms can be something that suggests endometriosis. Now, years ago, we used to do a surgery right away. So we would do a laparoscopic surgery, we would see what was going on, and we would treat the endometriosis surgically. Now that we have learned over the years that if you lower estrogen levels in the body, it treats endometriosis. We don't rush right to surgery for a number of reasons. One, obviously, general anesthesia is required for surgery. There can be various risks related to surgery, infection, injury to internal organs, et cetera. And two, we have a perfectly good treatment that we can initiate. That is some form of a hormonal contraceptive. And that's going to lower our estrogen levels, but still keep them in a safe range. And then if that doesn't work, then there may be the option for either going to a second-line medical therapy, which lowers estrogen further, or going to what we call a laparoscopy, which is where a small incision is made in the navel, in the belly button, and a camera is actually placed through there, and some air is placed in the abdomen to distend the abdominal wall so that we have a good look. But this has to be done, obviously, in the operating room with the general anesthetic. So the other reason for not doing the laparoscopy, besides the fact that there's effective treatment and it has risks, is that sometimes, as I said, we'll find something, but it's not the cause of pain. So we don't really know the true prevalence or how many women really have endo, because everyone's not had a laparoscopy. So we know that in people with pain, when we've looked, it can be between 50 and 75% with chronic gynecologic pain. But do we know whether those lesions are actually causing pain? So if the lesion is removed or cauterized and there's only pain relief for 4 to 6 months, we know that the pain is probably not just coming from the endometriosis. It may have been a part of it, but it's more complicated. We may have to address central amplification. We may have to address IBS, the muscles that we talked about. It can be much more complicated.
And a question just came up about Lupron for endometriosis, if you would mind just talking about.
Yeah, Lupron is what we'd call a second-line medical therapy. And I think it's generally not going to be used in any great amount in young teen years, because this is a time for trying to build peak bone mass. But if you take a birth control pill, if say an average estrogen might vary throughout the cycle from 40 to 400, and then you're on the birth control pill, your own estrogen is suppressed. It's barely measurable, but it's replaced by the amount of estrogen in the hormonal contraceptive, which will put you equivalent to about around 80, somewhere around there. Now, if you then go on something like Lupron, your estrogen is going to less than 12. That's like a menopause range. So that can be associated with bone loss and should only be taken for 6 months. Of course, hot flashes, mood changes, muscle pain, some of that can be prevented by taking a low dose of a progestin during that time, which won't stimulate the endometriosis. And so we use Lupron in situations where there's very severe endometriosis, or whether it's an important tool in an armamentarium for pain control for a short period of time. However, there's a newer class of drugs called GnRH antagonists. So Lupron is a GnRH agonist. So there's no dose response. It just takes your estrogen way down. The antagonists, you can have a dose response. So there's a medication called elagolix that you can take for up to 2 years, and it will lower your estrogen to about a mean of 40 as opposed to less than 12. And it has fewer symptoms, less bone loss, for the most part reversible, and FDA approved for up to 2 years. So that is another way to lower estrogen. And that would be considered a second line therapy. In some situations, the Depo-Provera can be considered first or second line. So that's just a progestin injected every 3 months, and again is going to thin the uterine lining, prevent menstrual periods. Same with the Nexplanon. You've heard about the rod, the etonogestrel implant that's used for contraception. Well, that can also be very helpful for cyclic pain because it blocks ovulation, thins the lining, prevents menstrual bleeding. Downside of these high-dose progestin-only preparations is that you can have poor cycle control. So you might have breakthrough bleeding here and there. You don't really know when it's going to happen, but also not harmful in terms of overall well-being.
Yeah, I really appreciate it. I mean, this is so much information. I feel like I'm going to go back and take notes from all things you said because it's so specific. And I also think that there's so much in here that can help us understand. And then when we go see the doctor, have a more meaningful conversation with regards to pain and with regards to its prostaglandin. Do some bodies overproduce prostaglandin or respond to it adversely, and that's why you're getting such a pain response? And also when you get this severe pelvic pain, and is that possible that you just could be overproducing or not responding to it properly?
Yeah, no, I mean, there's no doubt. Years ago, when they first discovered, when they were trying to figure out what caused menstrual pain, they were measuring prostaglandin production coming from the endometrium. And yes, there's no doubt that some bodies produce more prostaglandin than others. And I'm using prostaglandin in a way as a shortcut. There are a number of other chemicals that are involved in producing pain and increasing nerve firing that are produced by both endometriosis and by the inflammatory signaling process and during the period. But yes, some people produce more. And we think that there are probably individuals who genetically may be more prone to have more pain in the sense that they may produce more pain-producing chemicals or not break them down, or have certain other chemicals that change the way our brain perceives pain. So some of that can be genetic, and then some of these things can be changed. They can be changed by different behavioral and other approaches. So these changes that occur in the spinal cord and brain that have to do with having a lot of pain in the pelvis, that we call that neuroplasticity, meaning it's changeable, it's plastic. It's not like you've had a stroke or a brain injury. So when that happens and the brain has become more receptive to pain, we can completely take it the other way with different types of mind-body approaches and certain medications. It's not a permanent injury to the brain or the nervous system.
I think that is such an important takeaway, that we know that we can change this, because I think so often people say, I'm an estrogen body, I'm a this, I have cancer in my family. And I think basically telling people, maybe we shouldn't say that I am, because your family might have, but with neuroplasticity, you don't have to. And when people say I'm an estrogen body, is that something that is a legitimate medical term, or is that something we've just taken as a catchphrase? And what would that mean if it is a real thing?
No, it's really not a real thing. There are certain times when there is more production of estrogen, and that is typically in the perimenopause, which does not really affect your patients, because during that time, the ovaries, the follicles, the eggs are starting to die off, and the pituitary hormone is going up to try to stimulate the ovaries. And sometimes the ovaries will over-respond and produce too much estrogen associated with breast tenderness, headaches, excessive bleeding. But during the regular menstrual cycle, someone who has headaches, breast tenderness, bloating, and heavier periods does not have more estrogen than someone who doesn't have that. Now, it is true that if you don't bleed at all, unrelated to hormonal contraceptive, you may be lacking in estrogen. You might also, as you brought up before, have a lack of ovulation and just be lacking progesterone. And that's where we come into PCOS, for example. That is also, to some degree, an estrogen dominant condition because of the fact that you're not ovulating, but the estradiol levels are not necessarily that much higher in PCOS.
I mean, it's just such good information because we start to take new things and we give it life. And just like our pain starts to tell us it wants a life, we can change that and we can educate ourselves. I think as we come to the final few minutes, I would love to ask you what you've done so much research, you've seen so many patients. What do you think is the most, the advancement you've seen where you say, wow, this is really going to make a difference? And what would you like to see come out that for patients to make a difference?
Well, that's a tough one. I think two aspects. One is appreciating and understanding the role of the central nervous system, the spinal cord and brain in pain. Of course, we look for all of what we call the peripheral pain generators, everything going on where you feel the pain, but we know that without a brain, you can't feel pain. And so the understanding of all this interaction and how things become amplified and how we can dampen them, that is certainly a major discovery. And the second was, as I mentioned, the fact that we can lower estrogen levels, not all the way down, but lower them at a particular to a particular level and be able to treat endometriosis and to prevent endometriosis pain in a number of women by using various of the hormonal contraceptives. So I think those two branches were very important.
And it's making such a difference. I know so many kids that have said they had horrible periods and now they feel much better and are going back to school and getting over their pain. Real quick, if you don't mind giving us a quick tour of the PCOS, just because we did touch upon it for a second. So.
Okay. Well, the PCOS is a very complicated syndrome. It involves really not just the reproductive hormones, but chemicals being produced by the liver and pancreas. So it's really a state of insulin resistance, almost like type 2 diabetes, insulin resistance that's occurring in tissues and in the ovary. And what happens then is that little tiny egg sacs develop around the ovary, and they can be seen on ultrasound. They have to be over about 25 per ovary. So they've changed the number that have to be for the diagnosis, because a lot of young teens will have a lot of follicles and have irregular periods. And someone may say on ultrasound, oh, there's polycystic ovaries, but in fact, that's not the case. It's just normal. So they raised the number of follicles for the definition, or little egg sacs, from like 15 to 17 way up over the mid-20s, first of all. Now, the little follicles produce estrogen, but they don't actually ovulate. So what happens is if you don't ovulate, you don't make progesterone, and then you're not going to have a menstrual period. So again, in that sense, your endometrium, your lining can become thicker and it doesn't shed, and your periods may be very irregular. So you may have a period every 3 to 6 months, or even not at all. And in this situation, usually a hormonal contraceptive or just progesterone is given for half the cycle to shed the lining. But it can also be associated with excess hair growth on the body, or acne and weight gain. So the criteria for diagnosis, you have to have two components: irregular periods and excess hair on your body, or acne, or irregular periods, and in your bloodstream, the free testosterone is ordered and that's elevated, or the polycystic ovaries. So those are the three, and you have to have 2 of the 3 for the diagnosis. And it's usually treated with hormonal contraceptives, progestins, diet and exercise. And then if you're still not ovulating when you're ready to get pregnant, certain medications are used to allow for ovulation.
That was quite a great explanation in such a short period of time. And I thank you so much for all of this information. It's been incredible. And again, I'm going to go back and listen to it and take some notes. I think it was a wealth of information for everybody. So thank you. And thank you, everybody.
You're welcome.
We're right at 10:59, so I'm going to invite Georgia back to say what she would like to, but thank you so much again for your time and all of this.
You're welcome. My pleasure.
Yes, I definitely echo that. Thank you so much to both Dr. Rapkin and Dana for that incredibly informative presentation. And thank you all for joining us today and sharing your questions. This concludes our Pelvic Pain, Cramps, and Hormones, Why Does Our Body Communicate This Way webinar. We will be sending out the recording of this over email to you all in the next week. So keep an eye out for that in your inbox. And please feel free to contact us with any questions. You can also follow CHYP on social media for future announcements of webinars like this and other activities that we have. We have a Facebook, Twitter, Instagram, and YouTube channel that also houses our previous webinars that you can catch up on. And of course, you can look at our website by visiting mychip.org. So thank you again, Dr. Rapkin and Dana, for taking the time with me.
Thank you, Dana and Georgia, and thank you, Dr. Zelpser as well. Okay.
Have a great day, everyone.
Yeah.
Bye.